you very much for inviting me to talk. This is the only COVID-free talk today, but I hope it is of interest to you. I'm going to share with you my experience of using glue for mesh fixation in my abdominal wall reconstructions that I do. And that's not only laparoscopic, but it is open work as well. And we'll talk about some of that in a moment. I've been using the cyanoacrylate glue now for about 5 years, both in the laparoscopic form as liquid band fixate, Lapro, and more recently in an open form for our open abdominal wall reconstructions. And this is why I use it. I've had no end of complications relating to tacking and suturing of meshes in place. The only complication I've not had is a mortality. I've been always very wary of the diaphragm and the pericardium in that respect. Some of these penetrative tacks can get very deep at times, and even secure strap, the double-pronged tacker, can go very deep. And I've been trying to get away from that because I too have had colonic fistulas, small bowel issues with tacks, especially pro-tack in the early days. And there is good evidence that using tacks around the diaphragm is associated with a fairly high mortality risk if you get a cardiac tamponade. This is one of my patients. I carried out 12 years ago a bilateral laparoscopic inguinal repair for inguinal disruption. And 9 years later, she developed severe chronic inguinal pain on both sides. And here on the CT, you can see the pro-tacks. She was also getting bladder symptoms, and the bladder seemed to be irritated, and there was microscopic hematuria. And it wasn't until we actually did a laparoscopic removal of all the tacks that we actually resolved her symptoms 3 years later. And that was 12 years after the initial event. So how can we get rid of some of those problems with penetrative fixation for mesh? And that's certainly, I've been impressed with glue since I've been using it. And if you look at the hernia surgeons group, evidence-based from 2018, they recommended, one of their recommendations was that maybe we should be using more atraumatic techniques to fix mesh, especially with groin hernias. So this device, the Lapro device, a cyanoacrylate device, I started using 5 years ago, and it seemed to be easy to use. It's like a gun. It's got lots of shots, very easy to prime. It's got good fixation strength. If you look at the difference between that and secure strap, and this is for point-to-point fixation, it's superior to tacking devices. And we found it very easy to use, very easy to close peritoneum. It's got a very short setting time, 5 to 10 seconds. So you can close peritoneum in a tap repair. And one of the most striking things in our patients when they woke up, they didn't have pain, and we didn't use very much analgesia for our groin hernia repairs with tap. So this is a tap repair with a polyester mesh, and you can see the gun in use. We're fixing the top edge, which you would do with a tacker anyway. Very simple, acts like a tacking gun, but now we're going into dangerous territory. Pectineal ligament, pubis, which is notorious for pain after if you tack. We're gluing onto the iliac vessels, the inferior gastrix, and we're now on the floor of the dissection where the femoral nerve is. No worries about what's underneath. We can glue very safely in that area. So this is the peritoneal closure. We've dropped the pressure to 8 millimeters of mercury just to reduce the tension on the peritoneum. And we get a very good peritoneal closure with this, much neater than a tacked closure, and I think neater than a sutured closure. And with its strength, it can hold the peritoneum very easily. And I think it gives a more physiological closure of the peritoneum. So just finishing off the medial end, very simple. And we have a good seal, which we test at the end of the procedure. So that's a closure of peritoneum. And because we can use glue in areas where we can't tack, I think the extended fixation that we can do with glue can actually probably give a better result in terms of hernia recurrence. And we certainly can get rid of a lot of these penetrative complications. Now, this is an inguinal hernia. It's a left-sided M3, big defect, big sac. We've done the dissection, and we're going to do an extended fixation of the mesh. It's a polyester 3D hydrophilic mesh, Pariatex. We're going to glue fixate the top edge as we would do with a tacking or suturing technique. Very simple with this gun. And then we're going to fix well down onto the pubis. We don't want this to prolapse into the direct defect. So lots of glue on the pubis and the pectineal ligament. On the iliac vessels as well to stop it slipping, the inferior epigastrix now. On the floor of the dissection to stop it slipping. And then we can encircle the defect to stop it prolapsing into that defect. So I think this extended fixation might prove well in the future in terms of reducing recurrence. We did report our first experience in 2018 of our first 200 patients, 247 TAP repairs in hernia, and we had a low adverse event rate, only 6 seromas, 2.4%, 1 recurrence, and this was a median of follow-up of 29 months, and very low rates of chronic pain, which all resolved after a 6-month period. So we rolled it into our IPOM fixation techniques and started not long after doing our TAP repairs. So this is a laparoscopic IPOM repair of a cesarean defect, 5 centimeters diameter. We've closed the defect, so it's an IPOM plus. This is a Symbotex mesh, which is a polyester mesh coated with collagen. We're just getting in its right orientation. We have to have the polyester upwards, the collagen towards the peritoneum. And then we're going to use its stay sutures just to bring it up to the abdominal wall before gluing. So now we have to get the glue between the peritoneum and the mesh because it's not permeable. So we have to get the gun in the right position and start firing. And we're just fixing the central portion of the mesh where the marker is, the blue marker. Then we can fire several shots of the glue to try and spread the glue against the peritoneum. So several shots and just gentle pressure from below spreads the glue out. And there you can see a line of glue rather than individual points. So I think we can get a better surface area for fixation when we're using glue than we could with tacking devices. And I'll show you some evidence from our study that may prove positive. We can fix the edges, we can fix the near edge, which is difficult in laparoscopy. So that's a polyester Symbotex mesh with an IPOM fixation. And we've also had experience with biomeshes, and the bovine collagen dermal matrix made by Integra, the Surgimen, seems to work well with the cyanoacrylate glue. And this is a laparoscopic repair. The defect's been closed. It's an epigastric hernia, higher risk patient. That's why we're using a biomesh. This biomesh, you cannot tack through it, even though it's the thinnest 1 millimeter thickness. You cannot tack. You have to suture the mesh, and that is quite laborious when you're doing a laparoscopic repair. So with the glue, it works well. And you can see we're just spreading the glue as a sheet of glue, as a film of glue, to get good surface contact with the peritoneum. So I think the surface area for contact, for adhesion, gets a better adhesion, and that also helps with the biomesh integration as well. So that is a biomesh repair, laparoscopic IPOM. And we've recently published our early data in hernia in February of our first 137 patients. And these were predominantly midline repairs, not huge defects, mostly median diameter of 5 centimeters transversely. We closed most of our defects over 3 centimeters. And it was a combination of experience with Symbotex, some Dynamesh, and the bovine collagen matrix Surgiment for higher risk patients. And in a third of patients, we actually fixed the mesh to the diaphragm using the glue. These were for upper abdominal, right upper quadrant hernial defects. And again, our adverse event rate was low, very few seromas. And I think that is related to the fact that we can close the space between the mesh and the peritoneum very well with a film of glue. Low rates of hernia recurrence, and that may well be because we've got a lot of fixation, and low rates of chronic pain. And that median follow-up was 32 months and follow-up up to 4 years for those patients. So I think for laparoscopic IPOM, it is a good way to fix if we're going to use an IPOM technique. And it reduces pain, it reduced our length of stay. We could fix in areas which are difficult, such as the costal margin, the diaphragm, over the pelvic floor. Biomeshes are good, especially the Surgiment is good to use with the glue. And we have low rates of adverse events. Now, we're also using it in our open abdominal wall reconstructions, and I use it to fix mesh, both prosthetic and biologic, in the retrorectus position. And that saves a lot of suturing and issues with what's underlying that, the posterior rectus sheath. We also use it to obliterate the dead space between the mesh and the defect closure. We also use it for intraperitoneal biologic mesh as well, to bring it up to the peritoneum after doing stay sutures. And we've started to use it now in perineal hernia repairs to fix the pelvic sidewall, which is a very difficult area to actually fix with sutures. And as we said, using it for costal margin and diaphragm. I'm going to finish on just a case study. This is a lady in her 70s, following AP resection, who had 3 hernias, both a midline incisional hernia, large peristomal hernia, large perineal hernia. She was ventral hernia working group grade 3 modified, and her incisional defect transversely had an 8 centimeter diameter. And it was predominantly epigastric, but fairly extensive in length. Fairly significant peristomal hernia and defect and sac, as you can see, and a very large perineal hernia, which was the most symptomatic element of this lady's hernial defects. And our technique to repair this lady, we use a lot of Botox. Anything over 5 centimeters transverse diameter, I will Botox, and I use a ultrasound to use Botox, about 400 units, 4 weeks pre-op. We just opted to do a right-sided anterior component separation endoscopically. And following our laparotomy, we created a pelvic sling using 3 millimeter bovine surgical biomesh. And we fixed it to the bone, the pubis and the sacrum with bone anchors. And then we glued all around the pelvic sidewall to fix the mesh. Similarly, peristomal defect was closed and some sutures, but predominantly glue to fix another biomesh. And the incisional hernia, we used an intraperitoneal biomesh using glue, predominantly glue fixation before we close the defect. And this is a 9-month post-op CT scan. You can see there's good integration of the biomesh here with good vascularization, very little bulge at all. The parastomal defect is gone, and there's no sac there, no recurrence at 9 months. And interestingly, we've got a very good perineal repair. The perineal sling is holding well at 9 months. So I think the cyanoacrylates are good for abdominal wall reconstruction, very good in TAP repair, helpful in IPOM repair, and I'm finding better uses for it in open abdominal wall reconstruction because it's non-penetrative and we can get a good surface area for contact for mesh fixation. Thank you.
Okay, that was excellent, Paul. I will tell you something that it might sound like not quite objective and scientific. I was really curious about those glues, and I really started using this. I even have it here with me in the box.
Yeah.
I just did my hernia repair an hour ago.
All right.
Let me tell you my personal feeling when I start using this. This thing is really liquid. I mean, yeah. It really feels like water. So my first feeling when I start using this thing is, gosh, this is not going to fix anything. It's yeah. Just too liquid. Just yeah. It's like a water. So it took me a very long time to convince myself that this is really sticking things together.
Yes, yeah, indeed, yeah. We run some masterclasses where we show our candidates how well it sticks, and we stick the mesh to a lump of pork with several spots, and this pork is fairly heavy, and even a dead weight meat you can actually lift off the ground after fixing it. So that's the way I was impressed with the fixation strength rather than some of the data that's coming out. But we've now used it in over 500 TAP repairs, now 200 IPOMs, another couple of hundred abdominal wall reconstructions. And I think it's just getting that initial confidence with the use of glue, which is very different to a stitch or a tack, which seems to be more solid. I agree, it's just building confidence, really. Yeah.
Right. So you mentioned in your talk, really important thing that maybe some of us who don't really do a lot of hernias, like myself, might not quite appreciate it, which is that the one thing with mesh fixation is stabilizing it. Yeah. And we kind of know this very well. That's why we use tackers and stitches and all that.
Yeah.
But the point is, especially in inguinal hernia repair, that the mesh should be specially fixed in the lower portion of the mesh, yeah, where you cannot fix it with anywhere.
Yes.
And this is where recurrences are coming around that mesh below that.
Yeah. Yeah.
And there's no, I use Pro Grip and other things, but this is really where the glue comes into action. That tough areas that you cannot fix.
Yeah.
Do you have any experience with glue with any other biomesh than Surginet?
Not. I took up early with Surgimend and it just seemed to suit me and the glue very well. So I'm sorry, I've not any other experience, but I know I'm about to work with some Ovitex, which is the composite sheep bio and prosthetic mesh. And I'm informed by the Ovitex people that the glue would be suitable for their ovine biomesh. So I may be doing some cases when we finish with COVID with the Ovitex mesh. So I'm going to try it out with that.